I'm going to take you through some updates and insights on POLG mitochondrial disorders, including updates for the MitoPhen project. At the beginning, I'm going to give some introduction to mitochondrial disorders. As we know, mitochondrial disorders are disorders which result from dysfunctional mitochondria, and this could be because of variants or changes in nuclear genes or mitochondrial DNA mutations. And this is because mitochondria are under dual genetic control. So the mitochondrial function is controlled by nuclear genes, which are important for synthesis of phosphorylation proteins, as well as special DNA called mitochondrial DNA, which is present in the mitochondria in variable quantities or numbers, of course more in the organs which require high energy requirements such as CNS, muscles and liver. And mitochondrial dysfunction then results in phosphorylation effects, and this can result in very variable disorders. Individually, they're quite rare, but collectively, mitochondrial disorders can be quite common compared to other rare disorders. So it's estimated that 1 in 5,000 individuals are affected. And these can be multi-system movement, CNS, muscle, liver, etc. Very prone to metabolic variability, and it can affect children and adults. Because of this dual genetic control, mitochondrial disorders can pose some challenges in diagnosis, and it's estimated that 1/3 remain undiagnosed. However, next-generation sequencing, such as exome and genome sequencing, has much changed the landscape for diagnosis. And if we go further into mitochondrial disorders, we would find that there are different or variable functions of mitochondrial genes, and some of these are important in mitochondrial DNA maintenance, as we can see here, replication and maintenance. So these include multiple genes. One of these genes is POLG, but there are other genes as well. And defects in these genes could cause what we call mitochondrial depletion disorders. Mitochondrial depletion disorders then result in reduction in mitochondrial DNA content. However, they happen because of defects in the nuclear genes. So these are nuclear defects, but are important for mitochondrial DNA replication and maintenance. And this reduction in mitochondrial DNA content would lead to impaired energy production in affected tissues and organs. And these can either result from defecting genes which are important in mitochondrial nucleotide synthesis, as we can see here in this figure. So this group are important for the nucleotide synthesis, such as TQ2, RRM2P, GOP, etc., or mitochondrial DNA replication, such as POLG and Twinkle. Again, they are phenotypically heterogeneous, affecting children and adults, and they usually target organs with high energy requirements as well. So it can be myopathic, encaphalomyopathic, hepatocerebral, or neurogastrointestinal, such as mean representation, which is typical for E.U.P. They can have poor prognosis, however. Let's go then to POLG. POLG is part of the polymerase gamma whole enzyme. And the polymerase gamma whole enzyme is the only mitochondrial DNA polymerase. It is essential for mitochondrial DNA replication and repair, and it's formed of 3 subunits, 1 catalytic and 2 accessory subunits. POLG would encode for the catalytic subunit, the alpha subunit. POLG2 would code for the accessory subunit. And variants then would cause mitochondrial DNA depletions or multiple deletions. The POLG protein itself is formed of 3 domains. The exonuclease in gray, which we can see, important for proofreading and correction of errors during DNA replication. The polymerase in blue, which is important for synthesis of new DNA strands. And the linker domain, or the spacer domain, in orange, as we can see, important for stabilization of the complex and interaction with the other subunit, the accessory subunit. Let's get in. We have talked a little bit about the basic science part for POLG, but let's get into the clinical part. So POLG disorders are very heterogeneous, and they can have variable presentations. But the presentations I'm going to take you through in real life are overlapping. So these kind of distinct entities are not always there in real life cases. The first 2 presentations are myocerebral hypopathy and Alpers syndrome, and these are quite overlapping. Myocerebropathy presents in neonatal and infantile period, while Alpers syndrome is in infancy up to adolescence. In both of them, there is encephalopathy, developmental delay, liver disease as well. The early onset also have hypotonia and myopathy. In Alpers, typically there is refractory epilepsy, psychomotor regression, and liver dysfunction. And we can see here the abnormal MRI findings in Alpers and the liver disease in myocerebropathy. More to that later. The other presentation is Lee-like presentation. Usually in infancy, and patients would typically present with psychomotor retardation, hypotonia, extrapyramidal features, and this is because of involvement of basal ganglia, thalami, and brainstem, as we can see here in the MRI. So we need to think of POLG as part of the differential diagnosis of Lee-like presentations. The other presentation is Minji-like. We know that Minji typically is because of E.U.P variants, which is a mitochondrial depletion disorder. But POLG also, because it's involved in mitochondrial maintenance, can have a Minji-like presentation. Mitochondrial gastrointestinal encephalopathy. So patients can be in childhood, adolescents, and adults with GI dysmotility, with vomiting, diarrhea, or constipation, encephalopathy, social ophthalmoplegia, and neuropathy. The other presentation, there is this group of what we call MAMSA, or myoclonus epilepsy, myopathy, and sensory ataxia. Again, this is other features involve liver dysfunction, headaches, and stroke-like episodes, and usually presents in adolescents and adults. And within that, there is also a group of conditions called SCAI, or spinocerebellar ataxia with epilepsy. And we can see that there is a degree of overlap with the other earlier presentations. Here we can see the ragged red fibers, the box-neck fibers of these patients with myopathy. The other umbrella term is ataxia neuropathy spectrum. Again, presenting in adolescents and adults, they usually present with ataxia, neuropathy, cognitive impairment, epilepsy, and ophthalmoplegia. And we can see that they overlap a lot with the other groups. And also includes two maybe terms, MIRAS, or mitochondrial recessive ataxia syndrome, and SANDOS, or sensory ataxia neuropathy, tharthria, and ophthalmoplegia. Again, we can see lots of overlap. In addition to that, we can see that patients present with relapse-like presentation in adolescents and adults, stroke-like episodes, lactic acidosis. Here in the MRI, we can see the stroke-like episodes, and also here the COX-negative fibers. We can have, in some instances, seizures and migraines. The other maybe adult presentations are the autosomal recessive or dominant progressive external ophthalmoplegia. They can have ptosis. They can also have some of the other features like ataxia, neuropathy, and myopathy. Other adult onset presentations include Parkinsonism, recessive trachomere rhythmus-like neuropathy, and premature ovarian pain. And it's important to note the other presentations. One reason is sometimes they can present a bit earlier in adolescence, and the other is these can give very important clues in the family history. So you can see a patient with childhood onset or infantile onset, but then another family member has an adult onset presentation. And so these can be very important clues to POLG if someone has some of these presentations. As I said, these are quite overlapping. The earlier onset is usually associated with mitochondrial depletion in biopsies, like muscle and liver biopsies, while the later onset is associated with multiple deletions. And when we have lower number of mitochondrial DA, there is usually earlier onset and severity, such as liver failure and Alzheimer's. Then we can have all this, as we can see, the progression, which is more age-related. Now I'm going to present a case which can show us some pitfalls and insights about POLG disorders. And we can go in depth to look into some angles which can present some challenges in differential diagnosis. So this case is from the literature, as we can see. It's a child with unremarkable family history and early development. The child presented at age 3 with episode of ataxia, lethargy, and headaches associated with nausea and vomiting. These would last a few hours and occur monthly. And with a normal MRI and EEG, the patient was diagnosed eventually as having migraines. At age 6, the patient presented to hospital with resistant focal myotonia jerks and high-grade fever. Before that, the patient had some coryza for 3 days, and the initial workup showed neutropenia and lymphocytopenia, but normal inflammatory markers, normal lactate and transferases. Just X-ray showed right-sided consolidation, and the patient was started on antibiotics, but there was no other sinister findings on the infection workup. The myoclonic seizures persisted, and the patient was started on valproate, and also a continuous infusion of midazolam and thiopental because the seizures turned into status epilepticus. Was focal. Seizures stopped, and we know with these general anesthetics, there can be a burst suppression pattern, and so these were reduced. At the same time, a CSF analysis showed elevated proteins, normal lactate, no CSF autoantibodies. During the reduction of the general anesthesia, the EEG started to show these left-sided, rhythmic, high amplitude delta waves with superimposed distorted spikes and spike waves. And the brain MRI showed hyperintensity in the left thalamus, into flare and diffusion restriction as well. Epilepsia partialis continua worsened with continuous right-sided myotonic jerks in the hands. At this point, aminotransferase started to increase, so valproate was stopped and replaced with levetiracetam. And other anti-seizure medications were introduced, such as lacosamide, topiramate, and phenytoin. Because of the increased CSF and because of the MRI abnormalities, the patient was empirically managed as having an inflammatory condition and started on methylprednisolone, IVIG, and plasma exchange. However, the clinical condition deteriorated. Seizures were only partially controlled with a modified anti-seizure medication regime. And despite that the level of consciousness improved, seizures persisted. And then at day 38, seizures deteriorated worse, consciousness worsened, CSF showed much increase in the CSF protein, and also aminotransferases increased further. A repeat MRI showed at this point multiple T2 and flare hyperintensities in the left occipital gray matter, as we can see, also in the precentral gyrus on the left side, bilateral basal ganglia, in addition to the same region in the left thalamus. At this point, exploration or consideration of other potential causes of superrefractory status epilepticus were considered, and at this point, genetic testing for a gene panel for epilepsy started. Anti-seizure medication at this point was phenytoin, clobazam, and continuous midazolam. Despite the seizures deteriorating, there is now new left-sided myoclonic jerks as well. EEG showed continuous right-sided rhythmic delta activity superimposed fast and sharp components. Transaminases progressed, and finally serum lactate started to increase quite late in the disease course. On day 65, the myoclonic jerks persisted, and the patient had to be put again on thiopental goal. Despite that, progression to multi-organ failure sadly happened, and the patient unfortunately passed away. And as happens with many patients with genetic disorders, genetic test results only were available shortly after the patient's death, and it showed homozygous pathogenic POLG variant. This is the most common variant, and usually this is associated with Alpers-like precipitation. So we can see in this case a patient who presented initially with some vague history of paroxysmal episodes, we're not sure what was that, and then developed epilepsia partialis continua, worsened consciousness. Initial management was towards seizures, but also empiric management as an inflammatory disorder. However, the patient turned out to be POLG. And so let's maybe look at that angle first. Seizures and epilepsy in POLG. Seizures and epilepsy are hallmark features of POLG disorders, especially in pediatric onset cases, and they are often refractory to treatment. Some patterns are quite common, so focal seizures is the most common initial presentation. And these can include occipital lobe seizures, so visual hallucinations are quite common, nystagmus, motor seizures as well, like focal clonic-tonic, like we have seen in our case, they are quite focal. But also myoclonic seizures are common, often with ataxia, it can be spontaneous or action triggered. Epilepsia partialis continua, which is continuous focal epilepsy, is common as well. and it can involve different body parts. If there is epilepsia partialis continua and developmental regression or liver dysfunction, this is very much pointing to POLG. Generalized tonic-clonic seizures typically occur later in disease progression, though. And EEG can pinpoint us to POLG sometimes. So in the early stage, there is this RHADS pattern when there is occipital predominant rhythmic delta activity with superimposed spikes and polyspikes. And these were detected in the case I presented a couple of times, but overlooked. Also, patients can have photoparoxysmal responses. Later on, the patients would have multifocal epileptiform discharges, and in refractory cases, burst suppression pattern may emerge. And we have to know that subclinical seizures are known features of POLG, particularly in the adolescence onset or late childhood onset of MIMSA, myoclonic epilepsy, myopathy, sensory ataxia. We can see that there is age-related progression in POLG seizure patterns. So in infancy, epilepsia partialis continua and focal motor seizures are common. As I said, the presence of liver failure and developmental regression or delay can be a pinpointer. In childhood, occipital seizures are common, which can progress to epilepsia partialis continua and status epilepticus. Ataxia and neuropathy are common associated features. And in adolescents and adults, myoclonus in the context of MIMSA as well as focal seizures can happen along with ataxia and Parkinsonism. And the presence of seizures is associated with significantly worse survival and poor prognosis. The other concept here, which is overlapping with POLG, is Nour. So we know that refractory status epilepticus is seen in about 90% of Alpers syndrome cases. And it's often super refractory, failing to respond to 2 or more anti-seizure medications and general anesthesia. And we know that NOS, which means new onset refractory status epilepticus, which is a clinical presentation, not specific diagnosis, means sudden onset of status epilepticus, unresponsive to standard treatment, and the baseline investigations wouldn't show a clear underlying. And this was what was seen in our case. But NOS can have several causes, so sometimes it can be autoimmune but not readily identified very early. And this is why in many cases of NOS, they can be treated as if they are autoimmune with that assumption. But in many cases, these can be infections not identified early, or it can be of unknown cause. And overlapping with that is what we call FIRES, or febrile infection-related epilepsy syndrome, where NOS happens preceded by a preceding febrile illness. Again, this was what was seen to an extent in our case. It can be up to 2 weeks within the onset of status epilepticus. And in one study, it was found to up to 15% of NOS cases actually were found to have POLG variants. This is a very important concept, partly because many cases of NOS will just focus on the anti-seizure medications, and we should not use valproate if we cannot exclude POLG at this point. There are some key clues for differentiation of epilepsia partialis continua. I've chosen few causes, the most common ones, like Rasmussen encephalitis. Here we can see that there is this unilateral motor cortex atrophy and hemiparesis. POLG, as I said, seizures can be occipital, there is liver dysfunction, CSF lactate can be increased, not always, and valproate will trigger deterioration. Cortical dysplasia, like here, there is some cortical thickening or blurring in MRI. Despite that, sometimes we need maybe more higher intensity, like high Tesla, 3 Tesla, or even more MRI to find these cortical dysplasias, and may have balloon cells. Subacute sclerosis and panencephalitis here, they usually have myoclonus, periodic EEG complexes, and they can have white and gray matter involvement, and there can be history of measles. And other mitochondrial disorders, of course, we can find them by multisystem involvement, as these can cause also epilepsia partialis continua. The next aspect or angle here is liver disease. We have seen in the case I've presented that there's been transaminitis all through. So liver is a key target organ, particularly in pediatric onset cases like Alpers. And presentations can include acute liver failure, which is often triggered by valproate, but also by infections and fasting. And they can rapidly progress from normal liver function to fulminant liver failure, even within a few days. While chronic liver disease, including subclinical hepatopathy, with just elevated transaminitis or mild steatosis, can precede acute liver failure in many cases and can present unless specifically with failure to thrive, hepatomegaly, or recurrent vomiting. We can see here like a patient with ALPS, but quite advanced state with hepatocyte necrosis and loss and fibrosis. The problem with liver disease is, one thing is, liver transplantation is controversial in these cases of fulminant liver failure, because neurological progression would continue post-transplant. And because the median survival after acute liver failure can be less than 6 months. So in many instances, it's not done, even with fulminant liver failure, if POLG is confirmed. And liver failure often precedes worsened neurological decline. It's important in patients with liver impairment and refractory seizures to look for POLG. We must, or even if the liver impairment is very mild, even if there is transaminitis. And talking about valproate in POLG, so valproate is strongly contraindicated in POLG disorders. It significantly increases the risk of developing severe liver failure, and mortality can be up to 80% or more if used. And we have recently, with the Cambridge Mitochondrial group, I did a systematic analysis for valproate toxicity in mitochondrial disorders. And as I said, it's significantly associated with adverse fatal effects, even more than any of the other non-POLG mitochondrial disorders. Valproate is known to interfere with mitochondrial beta oxidation, and so this can be a reason of why it really precipitates or potentiates liver failure in this context. And we can see here, with the use of valproate, a marked decreased survival compared to non-use of valproate in red and blue. The other aspect which is important to talk about is neuroimaging. In the case I've presented, there has been some clues to pinpoint POLG. So patients with POLG disorders can have variable neuroimaging abnormalities, including cortical lesions, like that, and also the gray matter involvement. And usually the occipital cortex is involved, but also the other, like parietal, temporal, frontal lobes can be involved with these lesions. And stroke-like lesions could be observed in POLG as well. Usually unilateral, but bilateral lesions can be seen, and brain atrophy can be seen as well. However, white matter involvement is not as common. One important sign is the Berry-Rolandic sign, which is, I would say, pathognomonic, but very suggestive. So signal involvement in the Berry-Rolandic area could be pre-central gyrus or post-central. We can see here the pre and post-central involved. It can be very subtle, but we have to think of it. More frequently unilateral, more frequently pre-central. Also, thalamic lesions are common. Could be unilateral, bilateral. You can see here. Some thalamic lesions can be very subtle. Basal ganglia involvement as well. As I said, Lee-like presentations can be seen. In addition to that, cerebellum and brainstem are commonly involved. So posterior brainstem involvement is common, like here, like pontine tegmentum involvement, especially in the Miras syndrome. We can see bilateral dentate, nuclear hyperintensities as well, more in the Miras and the adult onset. And we can see here the hypertrophic olivary degeneration. So the olivary nuclei can be show hypertrophic degeneration as well. The significant cerebellar volume loss is not usual with ALPS, but it can be seen like here with Miras or mitochondrial recessive ataxia syndrome. There is very dentate abnormalities in addition to cerebellar volume loss. This is just a diagram showing how POLG neuroimaging abnormalities fits with other disorders. So we can see that there is predominant cortical and can be part of the differential of Miras. It's not usually using predominant white matter. Brainstem more posterior than anterior compared to the SERF1 deficiency, and basal ganglia predominantly ophthalmide, which can overlap with the Lee, OPA1 and CoQ1 deficiencies, etc. It's quite simplified figure, but I think very useful. The other aspect here is CSF and how we can use CSF abnormalities to suspect POLG. So lactate is increased in about 60 to 80% of cases, but it can be normal in the early stages. Plasma lactate is very unreliable for POLG and also mitochondrial disorders, to be honest. If there is normal lactate in the CSF or even in the plasma, we should not exclude mitochondrial disorders at all. Continue to genetic testing if suspected. Proteins are usually increased, but this is non-specific. However, with normal glucose and normal cell count, this can distinguish from other infectious and immune conditions. There are some red flags here for POLG. If you found these increased proteins with epilepsy that's refractory and normal cell count, think of POLG. If the MRI as well showing the thalamic occipital lesions, and if there is liver dysfunction, so elevated CSF protein with infective text is important. The main problem here is sometimes it is said that the CSF protein is increased because this is an inflammatory condition. Let's manage it as such. And I think this is what happened in the case I presented from literature. So no, it's not just in infections and inflammation that the CSF proteins are increased. And here is some differential diagnosis of some other conditions where CSF proteins can be different. Like if it's autoimmune, usually there is autoantibodies in the CSF, there is pleocytosis. In Lee syndrome, there is usually elevated lactate, with normal protein, so the opposite of POLG sometimes. And viral encephalitis, you can find the pathogen in PCR analysis. There is lymphocytic pleocytosis. Interestingly, it was found that in a subset of patients with POLG disorders, they may show elevated IgG index or oligoclonal bands, usually because of the chronic neuronal injury and secondary neuroinflammation. And these findings can lead to misdiagnosis and an immune condition, multiple sclerosis, or etc., delaying POLG testing. If we found a patient with oligoclonal bands or IgG index and there is no confirmation of an inflammatory or an immune condition, especially if there is liver dysfunction, refractory epilepsy, or if the MRI lesions are occipital and thalamic, or there is normal CSF cell count despite these, we need to think of POLG. So do not rule out POLG just based on oligoclonal bands or elevated IgG index alone, if there is no confirmation for an inflammatory or infectious process. And if you're going to try immune therapy empirically, please avoid valproates and seizure medication unless POLG is excluded. So in summary, the POLG phenotype features are really broad. I think this is another very helpful figure. It shows that the early onset, juvenile and adult, and late onset, how these can overlap but can differ. So PEO, for example, is not common in infancy or childhood. It's more like juvenile and late. Ataxia can be seen also. Liver disease is more like early to mid-age, not adults. These combinations are important. The elevated CSF and blood lactate is more with early onset, but not consistent. Neuropathy can be seen in all. MRI lesions more with the earlier onset as well as this elevated CSF protein. But if suspecting, do POLG testing. And I'm not going to get in depth into diagnosis of mitochondrial disorders, but at the moment, really targeted testing or probe testing, either by a gene panel of mitochondrial disorders or by exome or genome sequencing, is important. The era where, depending on muscle biopsy as a first-line test for mitochondrial disorder, is really now, because of the next generation sequencing, it's not the standard. And also, muscle biopsy findings in POLG disorders are really non-specific. You cannot do the muscle biopsy and say this is POLG. So please do genetic testing as broad as possible, especially with this broad differential diagnosis. Plus some aspects about phenotype-genotype correlations. So there are lots of variants associated with POLG. Here we can see like these variants are associated with Alpers syndrome. And usually the recessive variants, so having two variants, is typical with severe early onset disease like Alpers and intermediate phenotype, and also in some adult onset disease. But POLG can also be a dominant condition, especially with the adult onset conditions like PEO, Parkinsonism, and late onset ataxia neuropathy. Some variants are exclusively recessive, some are exclusively dominant, and some can be reported as both recessive and dominant. It's very important to discern that because there is different implications for recurrence risk and genetic counseling in a family if we think it's recessive or if we think it's dominant. And I personally have seen some reports, and also there is some cases in literature where it's clearly that there is just one variant, and the case is labeled as POLG, but this variant is typically a recessive, associated with recessive disease, and so the patient is a carrier, not affected. We have to be very careful with these fits. Here we can see the PEO-associated mutations in green. The recessive, in blue the dominant here in top, so there is again variabilities, and other mutations can be associated with other syndromes. The most common one seen in the patient represented, if homozygous, is usually associated with Alpers, but it can be compounded heterozygous with other variants causing later onset disease. These are the two second and third most common variants, usually with ataxia neuropathy syndrome and late onset epilepsy. And this dominant variant is the most common one associated with adult onset PEO. And just a quick word about MitoPhen, which is part of why we're doing this presentation today. So the MitoPhen project aims at systematic phenotyping and collection of genotypic data of mitochondrial disorders. Version 1 has been already published, and it includes data on mitochondrial DNA variants, and you can access that through the MitoPhen database. The second version is currently being published. It includes an expanded data set of primary mitochondrial disorders with all the phenotypic and genotypic data. And I had the maybe honor to be the one who curated the POLG data into the expanded version. And we have used it recently to diagnostic discovery of undiagnosed pediatric patients with POLG in the 100,000 Genomes Project. It's very important because it assesses diagnosis and enables systematic data-driven genotype-phenotype analysis. And through this phenotyping, we have had lots of insights about how really variable POLG disorders can be. At the end, just quickly talking that POLG therapies, at the moment, it doesn't have a curative treatment. But there is some promising treatments, including nucleoside supplementation. So giving oral deoxycytidine and deoxycytidine can bypass, or aims to bypass, the mitochondrial DNA replication effect. And it's also currently tried for other defects like TK2 deficiency. There has been trials with antioxidants, but some of these failed in clinical trials. Mitochondrial enhancers, which enhances mitochondrial biogenesis, again under trials. Small molecule therapies to improve the neuronal survival, and preclinical trials for gene therapies showed some promising results in mouse models. So at the end, POLG disorders are clinically and genetically heterogeneous. It's very important to recognize the red flags like refractory epilepsy, liver disease, occipital and thalamic MRI lesions, and episodic ataxia. These are critical to avoid diagnostic delay. CSF and imaging findings can mimic inflammatory disorders, but we can differentiate by cell counts, elevated CSF protein and lactate, and the specific MRI patterns. And in all cases, if you're suspected, do not use valproate, please. And genetic testing would remain the cornerstone of diagnosis. So hopefully with this presentation, I may have convinced you to think more of POLG disorders when you see a case with some of these maybe red flag presentations. At the end, thank you very much for listening.
Thank you, Professor Nour, for this interesting presentation. بحب أشكر أستاذنا الدكتور إبراهيم شكري والأستاذة الدكتورة لبنى منصور والأستاذة الدكتورة مريان يسري